So welcome everyone to this BJS Academy podcast. I'm delighted to have David Burling and Ian Jenkins from the St Mark's Complex Cancer team with me. David is a highly experienced, internationally regarded consultant gastrointestinal radiologist, and Ian is chair of surgery at St Mark's with an international reputation for his excellence in rectal cancer surgery. Both have a truly phenomenal experience in the assessment and management of rectal cancer, and recently authored a Young BJS article for the journal looking at the assessment and management of rectal cancer using Radiology Roadmaps. So welcome both of you, and thank you again. From personal experience, I know the team at St Mark's have some nuanced approaches to the MDT working and management and assessment of rectal cancer, and we're going to go through those. I'd really like to start by asking David, first of all, what are radiology roadmaps for rectal cancer surgery?
Thanks very much for inviting me, Martin. It's good to be here. So radiology roadmaps really are how do we translate the information we get from scans into useful sort of surgical decision making aids. And in simple terms, it's can we draw a dotted line along which a surgeon can cut out the tumour with a high chance of R0 histology. And so that's really what we're doing. We're translating the information from the imaging to the surgeon. The thing that's really important here, it is a radiology roadmap. We're not telling the surgeon how to do an operation, but we are using the combined experience and understanding of colorectal disease and the operations that are available to resect disease. So the radiologist who is perhaps best placed to identify how extensive the tumor is and what structures are involved are able to ensure the surgeon understands where that is, so that together they can work out what is going to be the best way of excising that. And I think over time you get to a point where the roadmap is probably pretty accurate to how the surgeon will then do the operation. But there's that critical step at which the surgeon will include the patient factors to differentiate the radiology roadmap created offline, if you like, in front of scans, and the surgical roadmap, which is the most relevant on the day.
Thanks, David. I had the pleasure of operating with Ian a few years ago, and I know at the start of the case we sat down and called in on one of the radiology team from St Mark's. Ian, I assume that's something you do regularly for these sorts of cases.
Yeah, and Martin, thank you for inviting us along to join you. Yeah, we rely heavily on our radiology colleagues for generating a plan or operative plan. David corrected himself. He said it was about the patient, but also about the surgeon. It is about both. The outline is not just for us. The outlines are very helpful for the patients as well. But we don't really feel we can go out safely into battle surgically without having a very clear battle plan. And David and his team generate that for us.
Yeah, I've come across discussion and seen you actually record a video of it, from what I understand, that you then can access on the day of surgery. Is that right?
And that's, I mean, I'll call David in on that, I suppose, a little later, but that's something that's evolved over time. That was something that was particularly relevant through COVID, where we didn't necessarily have our radiology colleagues immediately to hand, but our practice had been to spend time not only in our MDT, but also in the clinic, but also pre-operatively, often in the morning of the operation, going through the scans in detail, just to make sure that every aspect was considered operatively. And by necessity, we had to find a way of doing that in a different way. And vignettes had evolved whereby a video was taken. David will tell us a bit more about that. But that's something we'd been doing in the non-NHS sector for some years before all of that, just to try and simplify the process. I don't know if, David, you want to come into it at that point.
Well, I mean, I think being a good radiologist is also communicating the information in a way that's not only digestible, but also understandable, so that whatever I see in a scan in terms of identifying the disease, defining its extent, I need to get that information over to you fully so that you can provide the detailed surgical plan. And one way to do that is to do it basically in person, certainly so you can hear the intonation of my voice, You can see the images that I'm talking about at the time. And it's in a way bringing the MDT to whatever point of review you have, whether it be with the patient or in the theatre, so that you have a really clear picture as to what I'm trying to say. And so then you can translate that into the operation you do. So I think the vignettes are adjuncts to other forms of communication where, again, the radiologist is translating that information to the surgeon.
Thanks, David. And also, I'd like to say I'm very grateful you prepared 3 of these vignettes for the people watching this to have a look at what we're actually talking about when we look at this. And I think it'd be really useful to look through those. I also understand that you as a radiologist go to the surgical clinic. Is that right?
Yeah, it is. And again, just along the lines of improving communication so that we can try and minimize ambiguity between what I see and what Ian is thinking, the images show. And so going to clinic is really helpful. I think it is for lots of reasons. One is it's definitely a learning sort of hot pot, if you like. It's where I learn lots about the surgery and about patients and about that interaction. And that helps me with my focused review of scans. Similarly, I think, we can confirm, if you like, the MDT plan. Ian can ask any questions in an informal setting before the patient comes in. And then when the patient comes in, I think the patient benefits greatly from hearing it from the horse's mouth, not only listening and seeing their disease and trying to understand why they need such big radical surgery, but also I think by seeing the team and seeing the expertise across the different members, radiologists, nurses and surgeons, it's giving them trust to, succumbing, if you like, to the surgery, which is such a major thing for them to undergo.
Yeah, I have to say our local radiologists don't routinely come to clinic. I assume from your perspective, Ian, that you've seen a benefit from that, from the surgeon's eye.
I think I'd echo a lot of what David has said. I think it's not just the surgeon that benefits. I think the patient, the team benefits from it. We all understand a common language. There's a common point of discussion where everybody can reference things from. So I think it's been a particularly helpful thing for us to understand the radiology. I dare say we're far better at understanding images, particularly in MRI, than we were as a group 10, 15 years ago. And I dare say David's probably a lot better at examining and figuring out what's going on with a rectal cancer, having examined many patients in clinic and put the clinical context in relation to the radiology findings.
Yeah, I mean, just on that, Martyn, there's always limitations to both clinical examination and to radiology. And you really see that at that interface. So in clinic, I can examine a patient and realize that the radiology has been slightly erroneous, or vice versa. You can really, re-examine the patient with the radiology in mind, and suddenly it becomes much clearer. The other thing to say, Martyn, particularly from that patient interaction, we know how much of our communication is non-verbal and how important that is in conveying the intonation, the body language needed to bring a patient on board, or to explain why surgery is not feasible in them. And I think the face-to-face involvement of all the team is really critical for that.
Okay. You mentioned MRI scan as part of that. I mean, that probably is the workhorse of planning rectal or recurrent rectal cancer surgery. From the radiology perspective, do you think there are limitations with MRI? Do you think there's scope for improvement? And what does the future look like in imaging for rectal cancer, in your opinion?
Yeah, definitely limitations of MRI, just as there are with all modalities. And in fact, it's why we'll sometimes use different modalities like endorectal ultrasound and indeed just clinical examination, digital rectal examination to supplement the MRI. But there are lots of examples. I mean, I think the first thing you've got to get right is the quality of the MRI scan itself, because we're often presented, particularly in a post neoadjuvant setting, with whatever scans were done before. And if they're a bit blurry or not particularly high resolution, you end up having to wing it to some extent because you've got no choice. You're now post treatment. So getting quality of imaging is extremely important, and we can make mistakes with poor quality imaging. equally, the radiologist needs to be experienced, needs to admit when they don't know. Sometimes they identify the disease in the wrong place because they're not sure, but they sort of wing it. And I think it's really important there that you know exactly what you're talking about. If you're not sure, ask. And good examples are down close to the perineum, for example, well within the reach of clinical examination. You might see tumor going into the vagina from the anus, but you're not quite sure if the front wall of the vagina is involved, whether this is just involving the back wall, for example. It's that sort of thing where clinical examination is tremendously helpful. So there's lots of ways in which MRI is limited, but it's that communication that can sort of help break down where we're good and where we need to seek other support.
Yeah, you mentioned other modalities. The one that's sort of come into sort of reasonably regular practice in recent times is PET-CT scanning. Do you think this has a role in the staging of rectal cancer, locally and distantly, I suppose?
Yeah, I think PET-CT can be tremendously helpful. We tend to use it as a troubleshooting modality here at St Mark's. So I think if you've got the time and the experience to look at conventional imaging, MRI and CT, you'll find most of the answers you're looking for. But PET-CT is tremendously helpful for perhaps a residuum of disease within a heavily treated tumor that's predominantly scar tissue. Sometimes that can be really helpful. Also looking for CT occult mets, perhaps that bone met that nobody was suspecting that you can't really see on the CT. That's really helpful. We tend to have a low threshold for using PET-CT in complex cancer patients where you're making big decisions and the risk of metastatic disease is higher. And again, as I say, we use it for troubleshooting. So you might, for example, is that tumor extending into the sacrum from that pre-sacral deposit? The PET-CT might then show the tumor extending into the sacrum. So it can be really helpful, but you've just got to be also really aware of where you get false positives. Certainly wherever there's been a leak or inflammation, sometimes meshes in the pelvis can cause avidity on a PET scan. You just have to be aware of those so you don't overcall them.
Okay. I've got a surgeon's hat on, Ian, and neoadjuvant therapy is something that I think is a double-edged sword, if I'm honest. I think clearly it has some benefit. We are having problems with it, and in particular, we've had some cases recently where TNT has been used and the radiotherapy was 6-9 months ago. Really challenging those cases. Have you had similar experiences with neoadjuvant therapy?
I would agree. I would say any pelvis that's been irradiated is not easy, and the longer out from radiotherapy, the more difficult it is. And I suppose we're dealing with more patients that might have a regrowth, so they're perhaps longer down the line. So I think you're right. I think it does make things more difficult. But I think these cases generally are going to be difficult. A significant number are going to need some kind of neoadjuvant strategy. Problem is, I don't think we've really settled on what the best neoadjuvant strategy is for a significant number of these patients. I don't know, David, if you've got anything you want to say about some of the imaging issues we get with it.
Yeah, I mean, I think, obviously neoadjuvant therapy is tremendously helpful in some of the complex cancer cases we have, and where patients have had a good response and then go on and have surgery, we think that's really helpful. The problem, I guess, is that where you have an excellent response to treatment in the context of complex cancer, and then suddenly this tantalizing prospect of watch and wait becomes feasible and discussed, you then find patients who'd really rather not have a permanent stoma or potentially more radical surgery opting for this watch and wait. We know through work of Rob Glyn Jones and others that tumors can fragment as they retreat due to their good response. So you end up with little islands of cells where the original tumor went. We sort of think of this as the sort of high tide mark. We often use that in adenocarcinoma for where, what are the boundaries of the tumor around which we need to resect to help ensure an R0. But of course, in the setting of watch and wait, those fragments and islands of tumor can grow independently, creating a sort of slightly unusual pattern of disease. So indeed, you might be looking hard at the area that there was transmural extension and involvement of a margin, and actually the tumour is growing in another area, which you hadn't suspected. So that fragmentation of tumours and that watch and wait is certainly adding to some of the challenges for both timing of surgery and how the scans look. So yeah.
And from a surgical planning perspective, the fragmentation, I think, is a concern. Would you always plan your surgery based on the high tide mark? You know, if, sake of argument, you had a patient who had prostatic involvement or a butt in the prostate, has had neoadjuvant therapy, and then there might be a plane there might not be a plane. Would you tailor your approach to surgery or not?
Well, I think historically we've always taken the approach of go big or go home. Now, clearly things are evolving, and that sort of policy does need some moderation. But the sort of general view is that the prime objective is a complete pathological excision, so everything is tailored around about that. And as far as the data and most other things would suggest in the literature, that should still be the approach. But clearly, neoadjuvant therapy is evolving. We're seeing improvements in responses, and it does leave us open to the possibility that we use the term abbreviate surgery to some degree. Now, I suppose that comes down to a rather detailed discussion with a patient as to what the risks and benefits might be. Some will very quickly fall on one side, that they want anything that gives them the best opportunity of complete disease eradication. And others are maybe wanting something slightly more nuanced. And yes, we will negotiate with a patient based on the imaging, whether we think it's sensible, whether there's been a genuine response that would merit that. And that's where, I suppose, David, you would come in and tell us whether that's a sensible thing to do based on the imaging.
Indeed. Yeah, absolutely. I think the other factors that are involved here are particularly around histology of the tumour and sometimes the type of treatment involved. So I'm thinking particularly of squamous cell cancers and of tumours responding very well to immunotherapy. So we do tend to go with the high tide mark. We will acknowledge that treatment-related fibrosis is difficult to differentiate from tumour, and we will aim in the general sense, as you imply, in to give all of that a wide margin. But in those settings of immunotherapy, where you can often have a complete response from a really advanced, horrible cancer, it's very tempting to start thinking differently about the margins that we use. Similarly, for squamous cell cancer, sometimes you can have a very extensive tumour that responds extremely well, and you end up with a little nubbin of residual tumour. And again, it seems a big move sometimes to go around the high tide mark with a good margin. Equally, that may be appropriate in that particular patient if their trajectory of disease supports that.
And I suppose it comes down to understanding what the data show, accepting there's not a lot of high-level data to guide us as to what we should do. And we can refer to our own experiences as to what we can expect for a patient. Unfortunately, the literature is still not clear on what we should do, certainly with immunotherapy, in terms of how much we can abbreviate surgery, and we will have to advise a patient regarding that, and they can make a decision with us regarding that. Neoadjuvant therapies for rectal cancer, there's a little bit more data there to guide us, but still it's still not entirely clear, still a bit blurry, so patients are still sort of feeling slightly in the dark, albeit with us guiding them. And I think the scenario you mentioned about the prostatic threat, what do we do with that? Well, I suppose that again is in a negotiation, and I suppose it comes down to specific to an individual, how big their prostate is, how distant it is from the urethra, how much can we shave, do a partial prostatectomy en bloc, and what is a patient willing to accept in terms of a complete excision rate. We know that if we do that in selected patients where there's prostatic encroachment or involvement of the prostatic capsule, we can get it out with an R0 in about 85% of the time. There's about a third will get a urethral injury, and pretty much 80% can be managed with a urethral catheter in the long term, and that will eventually be removed and they will be able to be continent. based on our own data. That's only about 40 odd patients though. And there's about, I don't know, maybe sort of 15–20% that will have a prolonged urethral injury that requires prolonged urethral catheterization. And if they're willing to go through that, accepting a potentially slightly higher local recurrence rate, then we will potentially offer that to them.
Yeah, it is interesting. One of my mentors in my surgical training always used to say you get one good go at rectal cancer surgery, and that was the rationale for the radicality in his eyes. You had the high tide mark, and you have a phenomenal experience of dealing with recurrent rectal cancer. It's difficult to treat. It's morbid for the patient. So it is difficult to know where to draw those lines and where to put the compromises. But I think we probably need to reflect we're dealing with a malignant process, and that probably needs to be the priority, really. It's interesting you talk about immunotherapy. That really is probably the exciting new kid on the block. Really, my understanding or feeling about it is that it seems to work really well for the patients that it's suitable for. What we don't have is the maturity of the data, as you've alluded to with it, Ian. There are some problems. Pardon?
Sadly not. Yeah.
No, well, it's an evolution, I suppose, but it does seem very promising. I don't think we'll be out of a job just yet as surgeons. David will always be safe. Neoadjuvant therapy is not without risk, in my experience. I've come across more than a few cases where you could argue that the tumour was potentially operable, but it was felt neoadjuvant therapy should be given. Then the patients had a perforation on treatment. Is that something you've come across in your practices?
Shall I start with that, David? It's something that seems all too common in our practice. I think the concept of locally advanced rectal cancer is a very vague one, and I think people are often considered for neoadjuvant therapy, and that's evolved. The pendulum has swung very heavily towards TNT for a lot of patients, but they often have a clear circumferential resection margin. They may not even have vascular invasion and would have been suitable to go straight to surgery, certainly if it had been in our practice, but unfortunately bear the legacy of not only the neoadjuvant therapy, but what seems like, and again, we're very biased because we probably only see the ones that go wrong, a disproportionate number seem to perforate, and they go from what would have been a straightforward, in inverted commas, total mesorectal excision into something needing something far more unpleasant, far more extensive in terms of resection. It does seem to happen far more often than it should, David.
Yeah, and you'll get on, certainly on the continent in Europe. There are places that would advocate neoadjuvant treatment in patients with really quite early disease, question mark N1, early T3, N1, sat in the middle of the mesorectum that is miles away from the resection margins, and they'll have neoadjuvant treatment. And in that setting, of course, perforation's a disaster. Whereas, of course, what we try and do is go straight to surgery if it's reasonable and appropriate to do so. And so we're only really requesting or seeking support for neoadjuvant strategies where the tumour is compromising the CRM, or there are specific reasons in that patient to have neoadjuvant treatment. And then at least you can say, well, neoadjuvant was a no-brainer in this patient, and therefore if they then succumb to a complication, then sort of so be it. But it is a recurring theme, one that we talk about in virtually every MDT, is the overtreated patient that then ends up with an extended resection simply because of that overtreatment, and it's a sadly recurring scenario.
Coming back to image interpretation, once a patient's perforated, does that change the way you approach it radiologically?
Yes, absolutely. So classically we would say wherever the tumour has perforated to is potentially contaminated by malignant cells, similar to this sort of fragmentation, if you like. Wherever the cells go, tumour cells go, is potentially malignant. And of course, within the mesorectum, then that's contained. If it's within the peritoneum or above the peritoneal reflection, clearly, then we're talking about the potential for peritoneal disease. We tend not to take that so much into account surgically, because once there's peritoneal contamination, we sort of try and see if that develops into disease. Whereas within the pelvis, we will often look to create a roadmap that encompasses that the site and extent of perforation. I think that if that makes sense, Martyn.
Yeah, no, it makes perfect sense. I'd really like to thank you both for your time this afternoon. David, as somebody who gets lots of scans sent to you that perhaps you've not mapped at the point of referral, what sort of take-homes would you send to the rectal cancer clinical community out there about optimizing scanning for these patients? Any top tips?
Yeah, I mean, I think, we've now got a network, haven't we, through UK Pen and others, of complex cancer centres around the country. And so the threshold for referring a patient with locally advanced cancer should hopefully be much lower now than it used to be. And I would encourage a dialogue between centres without that special expertise to liaise and communicate freely with their MDT particularly. So, i.e. a low and early threshold for referral. And then with good communication, those referring centres will start to tailor the quality of their MRI technique particularly. So that means high resolution MRIing at the right angles, using the right sequences. And sometimes using Buscopan, particularly appropriate for a patient where you're getting blurring, repeating sequences. You get a classic is you'll get a protocol scan from a radiographer, and you'll get this scan that's always centered on the mid-rectum, whereas in fact the cancer was at the rectosigmoid, or indeed low down at the anorectal junction. There seems to be no tailoring of the scan to where the tumor is. And so just getting the quality of the scan, and then perhaps referring at the right time at the outset, because often again we'll get that post-neoadjuvant setting referral, and then you're relying on whatever imaging came first, whereas it would have been really helpful, for example, to get a PET scan at the outset to interrogate that indeterminate pelvic sidewall node. So good communication between referral centres and their local specialist complex cancer centre, and increasing dialogue that leads to better quality imaging at the outset, getting it right first time, if you like. That's what I would advocate.
And Ian, I assume from a surgeon's perspective, you'd echo that you'd want to be part of early decisions. I think so. Yeah, I think David made there's a thing for our non-UK sort of viewers, if you could call it that. There's a thing in the UK called Get It Right First Time, GIRFT, and I think that is the approach we need to be moving towards. Get everything done up front, early referral, early assessment, and if there's somebody that you don't believe is suitable, it's always still worthwhile getting a second opinion, particularly from a centre perhaps with a higher volume, perhaps a little more experience, just to affirm that is the right decision. Because I think sadly still, certainly I think in the UK, we see a lot of people that are still suitable for salvage, but are maybe not being given that opportunity. And we want to make sure that everybody has an opportunity that perhaps might not have been in previous times.
It is worth just throwing in there, sorry Martyn, is the fairly common scenario of a rising CEA from specialists, and of course some of these recurrent cancers are pretty subtle. It'll be a bit of small focus of low signal in the pelvic sidewall in a patient who's only having a CT scan as surveillance. And there seems to be sometimes a bit of independence between the rising CEA and the reporter of the surveillance scan. And I think sometimes they're getting onto that a bit earlier, rather than letting 3 or 4 scan intervals occur with a rising CEA, trying to recruit that specialist centre to support you in perhaps reviewing an MRI early to see why the CEA is rising, might just identify some of these recurrences earlier as well.
Yeah, it's interesting you mentioned about a second opinion, Ian. The older I get, the more I ask other people for opinions, it seems like. I'm getting less wise, it seems like I get old, or perhaps more wise, dependently.
I think it's a sign of maturity. A mature clinician does not fear a second opinion.
No. But thanks very much, both. I have to say, I really enjoyed talking to you this evening about this. BJS are very grateful to you for your time. Thank you very much.
Thank you, Martyn. It's been great speaking to you.